Hi, my name is Amy and this is my video discussing the pathophysiology and pharmacology of cystic fibrosis. Each individual has a cystic fibrosis transmembrane conductance regulator gene in their body that codes for a protein known as the CFTR protein. The gene is found on chromosome 7 and encompasses approximately 189,000 DNA pairs. This protein regulates the active transportation of chloride ions across epithelial cell membranes that line the airways, sweat glands, reproductive tracts, intestines, and liver. This chloride is crucial for the production of sweat, mucus, and digestive fluid, and it allows our bodies to maintain a homeostatic body temperature, correctly lubricate epithelial surfaces, and has more crucial functions. The CFTR gene codes for an integral cyclic AMP chloride protein channel that allows for the movement of chloride and bicarbonate ions across the epithelial membrane into the extracellular space. The activity of this channel downregulates the sodium absorption through the epithelial sodium channels, which increases the extracellular concentration of sodium. Additionally, water also moves out to the extracellular space due to the osmotic concentration gradient, which results in a normal level of secretions on the epithelial layer that is thin in consistency, which allows for normal functioning. The defective CFTR gene has an autosomal recessive inheritance pattern, meaning both parents must carry the defective gene for an individual to inherit it. In patients with cystic fibrosis, the defective CFTR gene causes either a complete absence of the protein within the membrane, a defective protein, or low-functioning protein, depending on the mutation. The defective CFTR protein results in a decreased level of chloride ion transport out of the cell. They remain in the intracellular space. The ion imbalance and dysfunctioning of the chloride channels disrupts the functioning of the epithelial sodium channels, which leads to the retention of the sodium ions in the intracellular space. Water is also being drawn into the cell with the sodium due to the concentration gradient, meaning the water is not in the extracellular space. This means the water cannot thin out the mucus into the necessary consistency. This results in a layer of thick, dehydrated mucus on the epithelial layer that has many impacts on the body's normal functioning. One drug used for cystic fibrosis is ivacaftor. Its brand name is Kalydeco and it belongs to the CFTR potentiator drug class. The ivacaftor binds to specific sites on the dysfunctional CFTR protein channel and keeps the channel open, which facilitates the movement of chloride ions out of the cell into the extracellular space. This will in turn draw sodium and water out into the extracellular space due to the concentration gradient. As a result, the mucus on the epithelial lining becomes thin as the water dilutes it. In order to take this medication, the cystic fibrosis patient must have a class 3 dysfunction of the CFTR protein, where there is a fully formed protein channel in the cell membrane, but it is dysfunctional. There are 97 specified mutations that this medication will respond to. The nursing considerations are as follows. The patient must be 4 months or older. Jacob is 16, so he is suitable. However, he first needs to be genetically screened to see if his mutation is one of the 97 that fit the criteria. The medication can affect the liver, so we need to advise both the patient and parent to notify us if they have any symptoms of pain or discomfort in the right abdominal area, yellowing skin or whites of eyes, nausea, and abnormally dark urine. We need to monitor his respiratory function. This includes pulmonary assessments to evaluate the effectiveness of the medication and monitor any changes in sputum and cough. We need to ensure the parents and Jacob are educated on the correct administration and dosage. We must also ensure they know the importance of adhering to the prescribed drug schedule to maintain therapeutic drug levels. There is an increased risk of cataracts in pediatric patients, so we must ensure that Jacob receives regular checkups at the optometrist. We must also monitor Jacob's nutrition, as cystic fibrosis patients generally experience malabsorption, which results in malnutrition. We need to continue to assess his nutritional intake and weight and refer them to a dietitian. We need to also ensure Jacob takes the medication with fatty food to improve digestion of the medication and absorption. Thank you for listening, and here are my references.